Well, we have a very interesting case, and our charge today is to show a live case that will be exemplary and tackle the problems that we all face when we do this in a multi-level patient. So, Asma, would you go ahead and give the
Yes.
presentation?
Hi. Good morning, everybody. So we have a 60-year-old male with usual risk factors, CAD, prior PCIs. He has reduced ejection fraction, CKD, diabetes mellitus, who presented to us for basically he has bilateral non-healing ulcers of both heels. And we already treated a month ago his left side. So he comes back now for the treatment of his right side. And he's on usual medications. Bilaterally, ABIs are actually very poor, 0.65 and 0.70 is after off the left side.
So, Mike, he's a brittle diabetic, and we've known him for some time. He lives in one of our outer boroughs, and so he gets treated by some of the physicians there as well. So he had an SFA procedure done over there that I think they opened up a tight lesion to help heal this heel ulcer, forgive the pun. And what happened was it hasn't been healing. So what we did was we brought him back and did an angiogram and set him up because I think he has some unique problems that are decision-making issues. Technically, again, there are some technical issues as well, but clearly there are clear decision-making issues in this case. So I'm going to have Dr. Guja play the case. Okay, so you see that he has a diffuse calcific SFA with a few focal tight spots. Next. Then you'll see that the popliteal is very, very calcified and eccentric, and you have a tight lesion. Next. Then you see that he has a heel ulcer, and the perineal has a long segment diffuse lesion. And the anterior tibial is not, I mean, it's maybe significant because he has an ulcer, but you wouldn't call that significant normally. And then this is an overlapped angiogram that shows that the AT is robust into the DP with good flow, but the perineal seems to supply the arch or the heel area. And you can see here the AT fills, and you can see late filling of a very, very diffusely diseased PT with a very poor plantar arch. Next, please. So then we did an intravascular ultrasound, but before that, let's go and show them the osteum. What's going on? Okay, that's the IVUS pictures, but I will show you those in a second. So the anterior, this is the common femoral, and you can see at this level, it looks eccentric, but when we did the IVUS, he has a very, very tight common femoral, and we're going to show you those areas when we start. So run the IVUS, please. And I think this is important when we have calcified lesions like this to do an ultrasound. And I learned this from D. Robertus, where he always says, figure out the areas with the gradients and then take care of the gradients. But what we use ultrasound because you have this eccentric calcium that makes it difficult to see the difficulty of the stenosis. So this is coming from the popliteal up, right? Or no, the perineal. Where does this come from? The popliteal up. So there you can see some calcium that's compressive, and then as you come further up, again popcorn calcium, but the lumen really doesn't have much plaque. We were initially planned. There you go. There's another area, and you saw that the ostium of the SFA. Can you show the still images?
The last.
Right. Now she's going to show you some still images. Oh no, runs. Okay, distal runs of the pop. So here, this is from the perineal up. Forgive me, I was just telling you the wrong way. And as you come up here, you'll see the popliteal, which is very, very tight. This is the proximal perineal, right? And that's the pop. This is the pop. A lot of plaque in this area. And I think ultrasound can help us to make a decision because on what type of therapy we're going to do. Already by looking at this in our minds, we're going to do some sort of atherectomy in the distal segment of the pop because there's a lot of fibrocalcific plaque. And then as you come into the SFA, you can see that your plaque is a lot less. And really the areas that are stenosed are the areas that will be compressed. So the areas, now we'll show them you saw the common femoral. So that's our idea, Mike. And the questions we're going to have is, how do you think we should treat the popliteal? We were planning on doing directional atherectomy in this area. And then how would you treat the perineal? And would you or would you not attempt the posterior tibial, knowing that it's so diffuse in the foot? Can you show the heel shot, please? So if you see the heel shot, Yeah, and Stephen, I'm curious on if Stephen's up there. I'm curious on their opinions in terms of whether you think opening the perineal, the popliteal, will help this heel ulcer get better because he has robust flow through the posterior communicating branch, and it looks like the heel is filling at this stage.
Yeah, so any of the panelists want to talk about angiosomes, or if you want to comment about whether you think that revascularization of a specific segment is of value.
Well, I mean, PK, coming to the topic of which target vessel to hit and things like that, I think we really have to have an idea of how big the wound is. I mean, if it's going to be a big wound and it's going to be on the heel, and it doesn't look like, even if you open the posterior tibial, it's going to open and stay open for too long.
Right.
My bet would probably be to optimize the inflow and to have a good, durable result in the SFA and the peroneal artery, maybe with some drug-eluting devices, and basically give the leg some time to heal up, without a re-intervention. So in these cases, I'll be more inclined to maybe use stents because, after all, it's a heel gangrene. If a heel wound, if it doesn't heal, he gets an amp. So probably I'll be more inclined to use stents in the CLI.
I don't want to belabor the medical aspects of this, but you described that he had bilateral heel ulcers. So the question is, how much of this is neurotropic? Was he down in bed for a time? Are these pressure necrotic or pressure necrosis heel ulcers? My experience has been that heel ulcers are very difficult to get them to resolve, and certainly optimizing blood flow, I think, is a critical piece, but then offloading and some of the wound care issues are also critically important in allowing them to heal.
So, Mike, that's a great point. He is an very active person. He's a brittle diabetic. He's had multiple ulcers of his great toes and other areas because of ischemia that we've treated on the left side, and they've all healed. The posterior tibial has always been occluded, and like Stephen said, has been very, very diseased. So the situation here is, Stephen, the perforation. All right, give me a balloon, guys. That's why I don't want to do two cuts. Balloon quickly, please.
PK, this is Fadi. Want to commend you on showing really real life cases here. One of the things that the angiogram also showed, I'm curious about the panel, is the unhealthy nature of the plantar loop. This is a patient that I personally would think about pedal loop reconstruction, especially with this type of wound. Even though, to Stephen, to your point, in terms of long-term patency, it's going to be a challenge. But anecdotally, our experience has been if most patients don't have an intact pedal loop,
give me a better balloon, please.
Their healing is challenging.
Balloon. Why did we do two cuts?
I think we have to balance it with putting the foot at risk. I mean, if it's going to be a small wound, then I agree. Maybe we won't do the pedal plantar, but it's whopping big gangrene, and you pretty much have nothing to lose because you really have to get maximum effort, and if it doesn't heal, then it's not meant to be. I would agree with that.
There's good evidence that direct angiosomal revascularization is more advantageous in terms of wound healing times and successful wound healing. But in this case, I think that perineal is pretty robust, and I'm not sure it's necessary. You can certainly heal without direct revascularization.
Yeah, I think some of the recent data that we have, though, with pedal loop reconstruction, to Fadi's point, has consistently shown that there's some better wound healing when you do inframillular work. So you could make an argument to treat the perineal and popliteal and then potentially still reconstruct the loop at the same time to maximize
the Japanese trial, rendezvous trial, published last year, our Japanese counterpart really showed nicely that the rates of wound healing are significantly better with the complete pedal loop versus the partial pedal loop for those patients. But if you talk about complete pedal loop versus partial pedal loop, it also falls into the angiosome distribution when you're treating those patients.
So I just want to ask you guys, as you see, we had a little bit of a perforation. And, Brian, I know you and I talk about this in Endomasters all the time. So we just made 2 passes with the Hawk 1M. It was a 5-millimeter vessel by Ivis. and this is what we ended up with right there. So the question, Brian, is at this stage, I know one of the things to the panel, we generally we'll do a prolonged balloon inflation that we're doing now, then what are your thoughts in terms of, do you think these kind of things can turn into pseudoaneurysms in the future if we don't put a covered stent? And then obviously you're dealing with what's the covered stent, are we going to use in this area?
Yeah, I mean, you and I obviously have had this discussion. I tend to just use balloon tamponade for these and try to get away from, avoid using a covered stent. I know you've had experience with some delayed ruptures of those, or delayed pseudoaneurysms, I think. I haven't seen that personally, but your comments on that have made me more inclined to use covered stents, for the reason that the mechanism of perforation with excisional atherectomy is you're actually shaving part of the wall of the artery there, and so you actually have a real tissue defect. So I've sort of leaned more toward using covered stents, but I still don't do them. In the few perforations I've had since we've had these discussions, I still don't use covered stents routinely. That said, this one looks like a fairly sizable sizable one, so you may find yourself using a covered stent. So I guess the next step here, you've got nice control of it. I'd probably say I'd get a balloon that's appropriately sized on a smaller platform, 014 or 018, to get down to where that perf is, maybe a little more distally, treat that vessel with that balloon, and get ready to put a covered stent in there.
Yep. So let's get a 4-0 balloon. So this is I think the situation. Wait, let's get everything ready.
So PK, I think what we should do is we're gonna go and give a talk.
Yep.
And allow you to clean up this a little bit.
Right.
And then we'll come back to you. So
So-
PK, you're on.
I'm
You're
on
on.
the screen, but I got to tell you. So what we had to do, I just want you to look at how this Viabond looks. Maga, please, on the Viabond for everybody. So you can see how the Viabond is outpouched right at the level of the perforation, and I think that's the spot that where we perfed. And now that we've covered the Viabond, we put a 60, right? 607, 7.607 centimeter, 75 Viabond, and we ballooned it with a 60 balloon. We'll IVUS it to make sure, but it definitely looks like it was expanded. The IVUS measurement of the vessel prior to was 5.7 or 5.6, right? So therefore, I think we sized it well with a Viabond. Unfortunately, I did not feel comfortable with CLI and all these things. He's probably going to need to be on a NOAC as well as Plavix because of his high-risk status with his vasculature. So then after that, we just went ahead and ballooned the perineal, as Stephen was suggesting, and I'm also interested to see what Fadi is saying. But I think that this posterior tibial in the artery in the foot is really quite diseased. So we're just going to try to increase our flow through this, and then see how he does. So, I mean, I don't know how many of you use DES below the knee, or is there one DES better than the other that you like? And that's kind of the question. So we ballooned this with a 3 millimeter, and we're using a 3038 DES. We don't want to jail the anterior tibial off, and so we're just going to go up now with the DES. Is there any particular DES you guys use one more than the other, or do you find they're all the same, or would you even put a drug-eluting stent here?
So the data for drug-eluting stents in randomized and unrandomized trials is very favorable, and especially in this type of scenario. But the problem, or not a problem, the issue with drug-eluting stents trials, most of the lesions are relatively short lesions. So you're doing very good if your lesion length is anywhere from 4 to 6 centimeters. But when you get into longer lengths and when you're getting into mid to distal tibials, then the performance of these devices is suboptimal. I don't have any I don't favor a particular stent over the other. Obviously, we know that the ongoing Saval trial with self-expanding drug-eluting stents in the infrapopliteal are ongoing right now in the United States, and we're eagerly awaiting the results. Aaron, what are your thoughts?
Yeah, I agree. I mean, I think that all coronary drug-eluting stents, I think, perform relatively equally in the tibials. The caveat being, of course, the data really is for these shorter lesions in the range of around 30 to 40 millimeters. So I'm excited to see the results of the Saval trial, though, too, because I think having a self-expanding stent with drug elution may have some significant benefits, especially for longer lesions.
Yeah, I don't disagree with any of that, and certainly the data is better for DES than anything else in the tibials in terms of patency rates. I guess the only caveat is that, as surgeons, we often encounter patients who have had their above-knee SFA and popliteal stented, and they go from, when those go down, they go from being above-knee candidates to below-knee bypass candidates, and that certainly impacts patency, at least with PTFE. And we worry about the same with tibials. As tibial stenting has been more adopted in recent years, I'm seeing patients with half of their tibials lined with a series of DES devices that impact could potentially impact their ability to maintain long-term limb salvage, because these tibials are the last line of defense. They're the last target we have for bypass. So that just has to always be kept in mind.
So we're going to look. We're having a little trouble getting the stent down, and just want to make sure it's not getting stuck somewhere. Where is it? It is getting stuck in our. The other one went smooth. So Brian, I'm curious on this particular one. No, it's not going by. Go back. On this particular case, would you have just ballooned that and left it, or would you have done something else?
Yeah, I don't use a lot of tibial stents. I mean, I do use them, but I don't use a lot of them for that reason I just discussed.
Right.
And so I typically will use atherectomy and balloon angioplasty. I can understand why you don't want to go back in with an atherectomy device right now, but typically I'm using mostly atherectomy and balloon angioplasty.
So PK, I'm gonna share the findings from Lutonix BTK, the 6 months outcomes. Let's have a discussion here. I think it's valid. Would any of our physicians here, obviously the BTK drug-coated balloons are not available in the United States, but would you use an off-label drug-coated balloon in this situation here? Obviously the one that's available for us would be a 4.0.
Yeah.
What do you guys think?
Yeah, and I think the 4.0 is generally not too oversized for these proximal tibials, and so I have used that.
Yeah, so we have also, Fadi, we've used them for but in this particular case, when you saw the perforation, there seemed to be a dissection at the level of the ostium, and you showed that picture would show the dissection. And I think at that stage we felt that, like what Stephen was talking about, that the perineal is going to be the primary vessel, minus one. There it is, right there. And then plus, go one more. And we ballooned it and then took another picture, plus. And you can see here that this was primarily the reason I felt that we should stent this. There's a lot of static in the microphone. Somebody turned on the hairdryer? Okay, so we're going to take a picture here and tell you how it looks, and then we'll look at the foot as well. Sorry to get you dizzy here.
I got it.
Okay.
That's the lowest.
So can you shut her in, please?
Yeah.
So I think, would any of you have left that perforation without a covered stent? I'm curious.
Well, if I'm sitting here, of course I will leave it. I will not do anything to it. But again, just commend you on showing real world cases, because you know what, the CLI work is difficult, and as a physician, I tell the fellows, it's not about avoiding complications. It's about when complications happens, what do you need to do, as you showed very beautifully in this case here. And you took us through the thought process. Why did you end up deciding to place a covered stent versus just treating it with balloon angioplasty? So,
No contrast.
I couldn't hear you. There's so much static in my microphone. I can't hear anything. There's so much static. It's
Can I
unbelievable.
have one more?
That's why I asked whether somebody's doing their hair. Okay, right.
No, we are changing the contrast. Yes.
Are we ready?
Contrast
No
is-
contrast? Okay. So, Mike, why don't you go to the next lecture if there is one, and because while they fix the technical issue here,
Okay.
and then we'll come back to you. So Mike, we stented that. I'll show you the pictures there. Now, we just want to evaluate the proximal. We did IVUS evaluation of that distal SFA, but didn't look significant. So now we're looking at that proximal and the ostium of the what is it called? SFA. So you can see there's something moving, sort of like a baby bouncing in a baby carriage, I guess.
Can we
But
show the
IVUS, can you show them the IVUS? There it is. I don't know what that is, right at the edge of the stent. So I think it might be a piece of calcium that they disrupted when they put the stent in. But I'm going to pull the IVUS back, and now I have Erin as well, who loves IVUS like me. We can decide whether we need to treat anything in this area to increase the inflow, because the outflow now is good, albeit it needed a covered stent, which wasn't planned. You can see the circumferential calcium with very little plaque. And again, here's some areas of, I don't know whether this is significant enough to treat, but we'll just keep coming back slowly. And here there's a lot of plaque and luminal compromise at this location, right here, which I marked. Can you mark that, please? Save that image. Okay. Save that image, please. Just save the image. Thank you. So we're just going to pull back further. And not much. We had a good lumen there. Just want to come back to the ostium, which looked suspicious before. See where we are. We're in the proximal. And that's not the ostium?
No.
All right. That's the ostium.
That's the ostium.
Yeah.
Maybe above. That's the ostium.
That's the ostium. So I don't know whether you guys would take care of this ostium. I don't know, or because it's really a complex issue because the profunda is also involved in that area. I don't know. I don't know. I think I may just leave, just do a Stellarex of that proximal lesion above the stent that we saw, and then call it a day here because I've got good outflow. Let's show the outflow. So we did the outflow pictures of the foot, which again was better than before. So here's the perineal. This had this kind of lumpy, bumpy look that was before. And then this is the area of interest where the ulcer is, the lateral heel ulcer. And you can see here, next one I think, yep. You can see the flow, it's actually keeping up with the anterior tibial and the perineal. And there you go, we had to inject twice to make sure that we saw it well. And that's definitely better in that particular area where the ulcer is. So my question is, I'm just going to do a Stellarex up top and not stent anymore. I think with the drug-coated therapy, with Stellarex having the ability to work in calcium makes me feel a little more confident. So I'm just going to go ahead and do a Stellarex balloon. But are you guys okay with kind of this? I know the covered stent was unexpected, but we would have liked to have done atherectomy and a Stellarex there. But we ended up having to use a covered stent, which I think is not so bad with this flow.
No, PK, I think you got a nice result in this, and I think you bailed yourself out admirably. How will you manage him, the patient, post-procedure now? It's a little more complex. You have a covered stent in place. Will it change your post-procedural antiplatelet therapy, either for either type or duration?
Well, there's no question, Mike. What we do is he has a baseline renal insufficiency. It's not too bad. His creatinine is 1.6. So what we'll do is we'll go ahead and use we hydrated him last night and prepped him for the procedure. But what we'll do is we'll use triple therapy for him for a month. We'll put him on aspirin, Plavix, and Xarelto. We'll adjust it for his creatinine clearance and make sure that we have Xarelto on board. Or you could use Eliquis, I guess, whichever one. And then we'll go ahead and do, after a month, we switch him off the aspirin and just put him on Plavix and Xarelto. And what we will do is keep this on. For him, I would keep it on at least for a year. Oop, I went down. I didn't step on the floor. Yep.
So now the Voyager finished enrollment for patients with post-intervention. We're really eagerly waiting because they have a sizable sample of CLI patients in those patients. So, and I remember the discussion from the earlier session talking about the COMPASS trial. This might be a great patient to maintain on just low dose rivaroxaban, 2.5 milligrams BID. I mean, the dose is available in the U.S. So you might make a case here. I mean, obviously, we're going to have to wait to see what Voyager shows, but this might be a good scenario for it.
So yeah, so I think that's what we'll do. We'll go ahead and do a triple therapy on this patient, and I think that in the long term, Mike, I think that's going to be the only thing that's going to be able to help him is good medical therapy and wound care. I think that the wound care part of it, we've got a very good wound care clinic that he goes to in the outer borough, and he's got a wound care surgeon as well as meaning a vascular surgeon as well as a podiatrist who takes care of him. So I'm not too worried about that part of it. But the issue here is going to be surveillance, and that's what I wanted to ask all of you. How do you survey these covered stents? And maybe Stephen or Brian can advise me when they put a covered stent in these kind of lesions. Does it change the way you survey these patients?
It doesn't for me. I'm pretty paranoid about covered stents going down. So often when I use a Viabon, I line the inside with a Supera, especially across the knee. But in terms of surveillance, I tend to survey my CLI patients every 3 months, or at least until their wound is healed. I tend to do a similar thing with claudicants, maybe every 6 months.
Anything different for you, Fadi, in CLI?
Yeah, so we have our PV follow-up protocol. So we see these patients at 2 weeks post-procedure, then at 30 days with an arterial duplex, ABIs, and office visit, and then we follow them every 3 months thereafter. That's for patients that are doing well. Obviously, any patient that has any signal for abnormality, then we take them out of a PV
I'll go
protocol.
up high pressure. Got it. How about you, Mike? Do you do anything different?
You know what? Honestly, no, but I so rarely use them that in my practice. So I will tell you that we would do our routine follow-up. I might be a little bit more aggressive with duplex ultrasound rather than just segmental pressures and Doppler waveforms in that setting. So I think I would include that as part of the surveillance.
So, but how do you treat? I know nobody likes to perf. Would you have stented this, Mike, with a covered stent with the size of perf that you had there? Down.
Yeah, you know, I think you know.
2 minutes.
The live case, you're under a fair amount of pressure. You know, when you have greater time, you know, you may have in a more relaxed atmosphere and not everybody's watching. You know, you could put a balloon up, leave it up for a longer period of time, and if I had had a reasonable result without extravasation of contrast after a more prolonged period of balloon inflation, I might have left it alone. But again, it's difficult to say, and I think. You know, again, you didn't quite have the luxury of time that you would have had perhaps in just a routine clinical setting in which you weren't being observed.
No, 100%. But you know, to me, when you look at this stent right here, and this is kind of what I always talk with Brian about this because we meet often. And you know, when the outline of that stent goes from flat to all of a sudden like having a belly like mine. Yeah, you can see that is the area I worry about, you know, outpouching and then the pseudoaneurysm developing. So that's I think regardless, Mike, even if I had time in this case with that kind of perf and with that kind of belly that I'm seeing there, I would probably have stented it. Karthik, how about you? Would you have covered this?
I would have covered it.
Yeah,
I would have
think
covered
so.
it regardless because of that. We just did 2 cuts. I mean, I know it was my suggestion to actually do the second cut.
No.
It's not PK's suggestion, but I really felt like that popliteal we had to atherectomize because of significant amount of atherosclerotic burden on the IVUS.
Yeah.
That's why I thought we needed, and it was a circumferential atherosclerosis on the IVUS. So I think that's why I felt like the second cut was necessary, but I didn't realize that it would.
Well, I think, Brian, also what I know you and I probably do the most on the panel. I don't know if Fadi does a lot of atherectomy or Aaron, but to me, in this situation, in the popliteal, I'm always wary with the new the M device, you know, because it is such an aggressive cutter. And would you know, do you normally do 2 passes, or do you take 1 pass, take a picture, and then do the second pass?
I think it also depends on your calcium burden. If you're cutting directly into a big piece of calcium, you can kind of tell that you're not, you know, how much you're doing, and often you're not doing that much on it. You know, but because of the aggressiveness of the Hawk 1M device, or any of the Hawk 1s, I will oftentimes use the old turbos or even sometimes the Silverhawk. They're phasing out the Silverhawks, but for soft lesions, you don't always want a very aggressive cutter, you know.
Right.
So I think they have a nice range of devices,
Yes.
but I like some of the older devices simply because there are times when you want to be a little less aggressive.
PK, I want to tell you though, I mean, retrospect, everything is easy, but looking at this lesion, I think it was the right choice to use directional atherectomy because of the nature of your plaque and the multi-level disease. You know, complications happen, but I mean, if I saw these images on IVUS, I think you made the right call by choosing directional atherectomy in this case here, just because of the plaque burden that we can see on IVUS.
Yeah, especially I think when we saw it here, it was so circumferential, the plaque. I think in one area.
This is the focal. That was the only cut we did.
Yeah,
and,
especially here.
And
See this
right
right here,
right there,
right
very
here.
soft and very much around the catheter. But you know, it's still eccentric though, Karthik. And the problem with the Hawk device is we're not able to direct it towards what we wanted.
Right.
And that's why I asked Brian that question, because sometimes when you do one cut and where you think, and you get surprised that you didn't cut where you wanted, and that's what happened. But you're right. I mean, hindsight is 20/20. But I think we got a good result. We've revascularized them. You saw that. Show the proximal picture. That I don't want to give too much dye. The proximal picture here with the Stellarex DCB is beautiful. We actually did touch the common femoral, the SFA ostium without a dissection, which I'm very happy with now. And that's gotten drug. And then we saw the flow to the foot. So we'll just do some runoff pictures now, and then we'll see you guys in the afternoon.
All right, very good. Let's give
Thank you.
PK
Nice case,
a round
PK.
of applause.
Thanks.
And,